A nasal or nasotracheal intubation is an intubation performed through the nose rather than through the mouth. It is frequently used during oral or facial surgery to improve access by avoiding the surgical site. Nasal intubation can be especially useful in the emergency situation because it's more comfortable and easier to perform in the conscious or semi-conscious patient than oral intubation. More important, nasal intubation can be performed blind, without seeing the vocal cords, making it useful in difficult intubations. Blind nasal intubation is less used in the hospital today because of other available techniques. The glide scope and the fiber optic bronchoscope are all examples of specialized equipment that can be used to intubate the patient with a challenging airway. However, these expensive instruments require specialized training. They may be unavailable at the time of an emergency and are not present with paramedics in the field. The technique of blind nasal intubation is still an important skill to master because it's a low-tech solution to a potentially life-threatening airway situation. Some of the indications for a blind nasal intubation include the patient with unstable cardiorespiratory status who cannot receive medications to induce unconsciousness or who lacks IV access to receive those medications, the anticipated difficult intubation, the patient who is predicted to be difficult to ventilate after induction of unconsciousness, such as the morbidly obese patient, with the use of cervical spine precautions to allow a more neutral head position and to allow monitoring of neurologic signs during the intubation, and intubation with the patient in an awkward position, such as trapped in a car accident. Blind nasal intubation may be difficult to perform in the uncooperative or combative patient or in the young child without sedation. Nasal intubation can offer advantages in a patient with facial trauma because of the disruption of facial anatomy interfering with airway management. However, nasal intubation with facial trauma is still somewhat controversial because there is a low but potentially serious risk of passing the tube through a fractured ethmoid sinus and into the cranium. Approach nasal intubation with caution in severe midface fractures or suspected basilar skull fractures. Since nosebleed is the most common complication, a history of significant nosebleeds is a relative contraindication. Use caution in children less than 10 years who often have hypertrophied adenoids, increasing the risk of nosebleed and tissue damage. The nasal route is contraindicated in the patient who is known to be anticoagulated or who has a coagulopathy. It should also be avoided in patients with infected sinuses or with anatomical abnormalities, such as nasal tumor. Don't use blind intubation techniques if possible if an oropharyngeal abscess is present to avoid rupture of the abscess with the tube. It's important to realize that the inside of the nose is not a smooth passage. On both sides, 3 masses protrude into the nasal passages from the lateral walls. These are the superior, middle, and inferior turbinates. Each turbinate is composed of a thin, curved layer of bone covered by mucous membrane. The turbinates serve to increase surface area to moisten air as it is breathed, and to protect the openings into the sinuses. Nasal intubation can damage both the turbinates and the mucous membrane covering them, leading to nosebleed. The nasal passages open posteriorly. The respiratory path then curves downward along the pharyngeal wall, leading to the laryngeal opening. Let's review the anatomy of the larynx. The larynx is a muscular tube in the neck that contains the vocal cords. It's the uppermost opening to the tracheobronchial tree and lies anterior to the esophagus. The larynx functions as a sophisticated valve that lets us breathe air, cough effectively, and swallow food and liquid without aspirating. Vibration of the vocal cords vocalizes sounds.
And take a breath.
The hyoid bone and the thyroid and cricoid cartilages principally form the laryngeal skeleton and give it rigidity and support. Attached anteriorly to the inside of the thyroid cartilage is the epiglottis, a curved leaf-shaped structure. Its upper rounded edge projects into the pharynx just behind the tongue. The stalk at the base of the epiglottis allows it to swing up and down over the laryngeal opening, opening and closing it like a trap door. The vocal cords are ligaments that project forward from the arytenoid cartilages to the inside of the thyroid cartilage. All the cartilages, ligaments, and muscles are covered by mucosa. The depression between the epiglottis and the tongue is called the vallecula. This is a typical view of the larynx during intubation. Here you can see the curved epiglottis above, the bulges of the arytenoids below. The triangular gap between the vocal cords is called the glottis. Above and to the sides of the true vocal cords are the false vocal cords. Look how close the esophagus is to the larynx. The ability to breathe effectively and carry out the other laryngeal functions depends on coordination of many muscles. The glottis normally widens during inspiration and narrows during expiration. This dynamic control of airflow reduces resistance to breathing with both faster inflow and outflow of air as effort demands. The harder you try to breathe, the wider the larynx opens. This trait can be very helpful in blind nasal intubation. Protection from aspiration also depends on muscle coordination. During swallowing, the whole larynx rises in the neck, the epiglottis folds over the glottis, and the tongue and pharyngeal muscles direct food and liquid backward into the esophagus. However, the same flexibility can allow the epiglottis to fold over the larynx and block the opening during intubation. When muscle tone is lost, the epiglottis, tongue, and other pharyngeal tissues fall backward, blocking the larynx and obstructing breathing. A good example of this from everyday experience is snoring. Laryngospasm, an intense reflex protective closure of the vocal cords, is a good example of how dynamic the larynx actually is. It typically occurs by stimulating the vocal cords while the patient is semi-conscious. Laryngospasm can be so strong that it obstructs ventilation and can physically prevent insertion of an endotracheal tube. This is laryngospasm, caused in this case by the endotracheal tube touching the left arytenoid in a patient who was lightly anesthetized. Watch closure of the vocal cords, closure of the false cords, and mounding of the paraglottic tissues by elevation of the larynx. The protective movements of the larynx during swallowing, gagging, and laryngospasm can hinder blind nasal intubation and must be taken into account in preparing the patient. Oral intubation relies on bringing the path from the incisor teeth to the larynx into a reasonably straight line by aligning the oral, pharyngeal, and laryngeal axes. Since these axes don't naturally line up, oral intubation depends on optimally positioning the patient's head and neck and then using the laryngoscope blade to make the final adjustment. During blind nasal intubation, the path that the nasotracheal tube will naturally tend to follow from the nose to the larynx is curved and more easily aligned when the head is in a neutral position. When examining the patient prior to nasal intubation, evaluate the external anatomy. To detect nasal obstruction, pinch off each nostril and feel the amount of air exhaled through the other. The right nostril is often more patent than the left in the majority of patients. Look for septal deviation. When possible, avoid the affected side of the nose if there is a history of nosebleeds and sinusitis. Preparation of the patient is important. Nasal intubation is more difficult in a poorly prepared patient because even the semi-conscious patient may reflexively protect their airway if their gag reflex is intact. A combination of local anesthesia, vasoconstrictors, drying agents, and sedation will provide you with a more cooperative patient. The clinical situation and the amount of time you have will dictate how involved a prep you can perform. At the very least, anesthetize the nose using a combination that both numbs and vasoconstricts. Except for cocaine, all local anesthetics dilate blood vessels. Vessel dilation can produce edema, forcing the use of a smaller tube and making nosebleeds more likely. Vasoconstrictors aid tube passage and minimize bleeding. Use any vasoconstrictor nasal spray or nose drops. To numb the nose, spray both nostrils with a topical anesthetic spray or place 2% lidocaine ointment in the nostrils to melt. Using a topical oral spray as well helps to decrease the gag reflex. Passing a nasal airway coated with local anesthetic ointment enhances the numbing. It also tests the passage for evidence of obstruction with a softer, more flexible tube. It can give you an indication of what size endotracheal tube to use. Place the nasal airway gently and never force it. Insert it perpendicular to the plane of the face and not at an angle. Don't force it if you hit an obstruction because the nasal airway could tear one of the turbinates. Choose a smaller size or try the other side if necessary. Occasionally, a transtracheal block or other nerve block is added in the hospital setting. Systemic local anesthetic toxicity is possible with repeated applications and use of multiple routes of administration. Local anesthetic uptake through mucous membrane is rapid. Calculate the total dose of local anesthetic to be administered before you start. Limit plain lidocaine to less than 5 milligrams per kilogram. Use of an intravenous drying agent such as either atropine or glycopyrrolate, also called Robenil, decreases airway secretions and reduces the risk of aspiration. Drying agents can take 10 to 15 minutes to work. Sedation works quickly, provides amnesia, increases comfort and cooperation, and depresses airway protective reflexes. Safe use of such agents depends on constant reassessment of the clinical status of the patient. Never abolish a protective reflex unless you can provide an equally safe substitute. Always guard against aspiration, especially if you anesthetize the larynx and trachea in addition to the nose. Constantly monitor the level of consciousness and the adequacy of ventilation and oxygenation. Sedation in an exhausted patient suffering from hypoxia can produce apnea with little warning. You can use a standard endotracheal tube for nasal intubation. Another option is the nasal ray tube, a specially molded tube often used for facial surgery since its curve brings the adapter up over the forehead and away from the surgical field. Because of the OR setting in this video, you will see the nasal ray tube used often. Additionally, a nasal tube is available with a flexible tip that allows the curve of the tube to be varied by pulling on a control ring. This is called an endotracheal tube. Regardless of the type of tube, the basic technique is the same. Tube size is a compromise between selecting a size small enough to slide atraumatically through the nose, while using the largest diameter possible to minimize resistance to breathing. We typically choose a nasotracheal tube 1/2 to 1 size smaller than for oral intubation. Alternatively, select a tube just slightly smaller than the diameter of the patient's nostril. Avoid using a tube that is too small. Depending upon height, an adult nose can usually take between a 7 and an 8.0 tube. Check the cuff for leaks before you start. Warming the tube in hot water, if available, makes it more pliable and easier to pass. Lubricate the outside of the tube well with local anesthetic ointment. The success of blind nasal intubation depends on positioning the head so that the larynx is in alignment with the natural path of the tube as it passes through the nasal pharynx. Optimally, the patient should be breathing spontaneously because the patient's breath sounds are used to guide slight changes in head position and tube angle. These final adjustments allow the tube to slide into the larynx. Watch the animation again and observe that the tube is usually advanced during inspiration when the cords are most open. Unless contraindicated by concerns for cervical spine injury, position the head about 10 centimeters or 4 inches above the bed. Use a neutral or slightly flexed head position, since this usually brings the larynx into good alignment with the nasotracheal tube after it turns the corner into the posterior pharynx. Head extension makes the angle that the tube must turn more acute, and the tube is more likely to enter the esophagus. The right nasal passage is larger in more than 85% of the population. Direct the tube towards the opposite left shoulder when the right nasal passage is used. This will help you place the tip of the tube near the midline. If using the left nasal passage, direct the tube towards the right shoulder. Don't thread the tube towards the frontal sinus, a painful maneuver likely to cause a nosebleed. Slide the tube straight back, parallel to the floor of the nose, just like a nasal airway. Advance the tube until you feel a slight give. The tube has just turned the corner into the posterior pharynx. This loss of resistance is often quite abrupt as the tip of the tube passes the turbinates. Be gentle. The middle turbinate is fragile in most patients and can be fractured or torn. Slowly advance the tube during inspiration, when the vocal cords are most open. Listen to the breath sounds through the tube. Continue to advance the tube. If the patient is conscious, ask the patient to take a deep breath and gently advance the tube during inhalation. If the patient is unconscious, time advancement of the tube to coincide with inhalation. You'll know the tube is in the trachea when you still hear breath sounds after you reach the correct depth of insertion. Depth markings will be 26 to 28 centimeters at the nose in the average adult. The patient will often cough when the tube enters the trachea. Be prepared to stabilize the tube or to prevent head or neck movement if you're protecting the cervical spine. Inflate the cuff. Don't let go of the tube until it's been secured. Breath sounds can sometimes be hard to hear if the environment is noisy or if the patient is breathing shallowly. There are several ways to make it easier to know the tube is taking the right path when it's hard to hear. If the patient is hypoventilating somewhat, use your opposite hand to obstruct their mouth and left nostril. This will enhance air passage through the right nostril. Don't interfere with the patient's ability to ventilate. However, you can briefly perform this trick and enhance airflow sounds. If the patient's not breathing adequately, stop the procedure and immediately begin assisted ventilations. The BAM, B-A-A-M, or Beck Airway Airflow Monitor, is a disposable device that connects to the standard 15mm endotracheal tube connector. A whistling sound is made as the patient breathes in and out. This helps the intubator hear when the tube is approaching the laryngeal opening. If the tube enters the esophagus, the whistle sound is lost. If you don't have a BAM, you can use an end-tidal CO2 detector on the end of the tube to indicate when you have the tip of the tube close to the glottis. If you see color change, you're on the right track. The more intense the color change, the closer you are. Check immediately to make sure that the tube is correctly positioned in the trachea. Listen for bilateral breath sounds. When you ventilate the patient, the chest rises as you squeeze the bag. With the patient breathing spontaneously, you'll feel air moving in and out of the tube. There is bag movement with each breath. This is easier to feel with a free flow or plenum style bag rather than a self-inflating style bag such as the Ambu. End-tidal carbon dioxide will be present if you have a carbon dioxide monitor. You will see condensation inside the tube. The awake patient won't be able to speak. A mainstem intubation occurs when the tube is inserted too deep into one of the mainstem bronchi. The breath sounds will be unequal. To correct this, suction the mouth well to clear any secretions, deflate the cuff, and slowly pull the tube back until bilateral breath sounds reappear. Reinflate the cuff. If breath sounds are still unequal despite the tube being at an appropriate depth, then tape it in place and get a chest X-ray. Consider other causes of unequal breath sounds such as pneumothorax. In addition to checking to ensure that the tube is not too deep, also make sure that the cuff is not too high and that it's below the cricoid ring. When properly positioned, squeezing the pilot balloon will allow you to feel the cuff move slightly at the tracheal notch. If the cuff sits partially inside the rigid cricoid, it can press on and potentially injure the recurrent laryngeal nerves, causing either transient or possibly permanent vocal cord paralysis. If the cuff is above the cords, the tube may bow in the posterior pharynx. This can trick you into thinking that the tube is correctly positioned because it seems to be at the correct depth. Because the tip of the tube is in the trachea, you'll feel and hear breath coming from the tube. You may even be able to ventilate the patient through the tube, although there will be a continued leak that won't resolve with repeated inflation of the cuff. The tube will tend to keep backing out of the nose in this situation.
I don't think it's all the way in. Turn your neck back this way. Thank you.
The patient can easily be extubated if the cuff is above the cords. Deflate the cuff and gently advance the tube.
A bit more. Deep breath. Take a deep breath. Deep breath, deep breath, deep breath, deep breath, deep breath, deep breath.
Re-verify placement. It's easy for the tube to slip off the back of the larynx and into the esophagus with this maneuver. You can secure a nasotracheal tube in a number of different ways. Whichever way you choose, it's essential that there be no tension pulling the tube against the tip of the nose. Excessive pressure against the tip of the nose can cause ischemia, leading to tissue death and permanent scarring. Once secure, suction the tube to clear any secretions. Blood or tissue may be present. A suction catheter should pass easily through the nasotracheal tube. If the catheter won't pass, then the tube may be bent in its passage through the posterior pharynx. An abrupt bend in the tube may partially obstruct it, increasing the resistance to breathing. It also impairs the ability to suction the tube clear of secretions. Pulling it out or pushing it in slightly may allow it to curve more smoothly and relieve the kink. Be careful to avoid extubation or mainstem intubation. If the tube still won't allow passage of a suction catheter, consider replacing it with either a larger nasal tube or an oral tube at the earliest safe opportunity for the patient. Always re-verify tracheal placement whenever you reposition the tube or if you move or reposition the patient. The two main problems with nasotracheal intubation tend to be difficulty passing the tube through the nose into the posterior pharynx and problems getting the tube to pass into the trachea. When passing the tube into the nose, never force the tube if you feel significant resistance. The tube tip could dissect under the mucous membrane into the retropharyngeal space. Choose an appropriate size for the patient. Make sure the tube is well lubricated. Try to gently twist the tube to allow the tip to pass between the turbinates. Alter its angle slightly. The tube will often slide past the obstruction. If the tube still won't advance, then switch to the other side or try a smaller tube. Sometimes the tube won't pass easily into the trachea. Breath sounds are present as long as the tip of the tube is aligned with the trachea. If the tube passes into the esophagus, breath sounds vanish. The patient may gag. Stop. Pull the tube back until you hear breath sounds again. Redirect, then slowly advance once more. The tube tip can also catch in the vallecula or piriform sinuses, spaces behind the epiglottis near the base of the tongue. In this case, you'll hear good breath sounds but won't be able to pass the tube. Changing either the angle of the head or the angle of the tube will often bring the tube into alignment with the trachea. Catching in the vallecula may cause the tube to bow in the posterior pharynx. Even though you can hear breath sounds, the tube usually keeps backing out of the nose in this situation. If head or neck movement is not contraindicated by possible cervical spine injury, manipulating the head or neck can often help align the tube tip with the larynx. Try turning the head slightly to one side. If movement in one direction doesn't work, turn it the other way. Change the degree of flexion or extension. Have an assistant apply cricoid pressure by placing thumb and index finger on either side of the cricoid ring and pressing downward. Have an awake patient stick out the tongue or have your assistant grab the tongue with a 4x4 and pull it out. Picture where you're aiming the tip of the tube and adjust the head accordingly. A tube placed in the right nostril tends to cross to the left lower pharynx. Therefore, moving the head slightly to the right of midline for a right-sided tube will align the trachea with the tube. For left nasal intubations, move the head to the left. Pushing the larynx towards the side opposite the nostril being used can also help. Remember, any manipulation of the head or neck must take into consideration the risk of cervical spine injury. Observe the neck for lateral displacement from the tip of the tube. One trick to help the tube to align itself in the midline is to partially inflate the cuff of the tube after you pass it through the nasopharynx. This may bring the nasotracheal tube in line with the laryngeal opening. While the tube will often start down the trachea, you will probably need to deflate the cuff to get the tube to completely pass through the cords. The use of a type of endotracheal tube called an endotracheal tube can facilitate blind nasal intubations. Nasotracheal tubes sometimes enter the esophagus because they won't curve forward enough when entering the nasopharynx. Endotracheal tubes solve this problem with a pull cord attached to a ring near the 15mm adapter. Pulling the ring lifts the tip anteriorly, allowing you to position the tip with more precise control. Natural airway protective reflexes may prevent the tube from passing. Sometimes further topicalization and/or sedation will smooth the intubation. However, you must weigh the risks of these maneuvers versus the benefits. A heavily sedated patient with a numb larynx can aspirate. There are times when a nasal intubation is desired in an apneic patient. This situation most commonly arises during elective surgery when nasal intubation is performed after induction of anesthesia. You can use your laryngoscope to assist. This combined technique is easier in the unconscious patient because of the absence of a gag reflex. To use this technique in an awake patient, good topicalization plus glossopharyngeal nerve block is helpful. Place the nasotracheal tube through the nostril and advance it until the tip is in the posterior pharynx. Visualize the larynx with your laryngoscope. Once you see the larynx, hold the laryngoscope blade firmly in position. You can often push the tube forward with your right hand and direct it into the larynx. The breath sounds can guide you when you can't see the larynx clearly and the patient is breathing spontaneously. Watch the laryngoscope-assisted intubation and cross-section. If the tube is still bypassing the cords, you can use a McGill forceps to direct the tip. Never grasp the cuff itself with your forceps. You can easily rip it, leaving no way to seal off the trachea. Grasp either the tip of the tube or the area behind the cuff. If you damage the cuff, then discard that tube and use a fresh one. Insert the nasotracheal tube through the nose. Visualize the larynx with your laryngoscope. Then, have your assistant advance the tube further through the nose while you guide the tip of the tube with your forceps. Your assistant must position herself to avoid blocking the view or bumping your arm or the laryngoscope blade. Good communication is key to the teamwork involved. Watch the technique in cross-section to see the sequential use of the instruments. Another useful trick is the use of a nasal airway in the opposite nostril to assist breathing during a blind nasal tracheal intubation. First, insert an endotracheal tube adapter into the nasal airway. Place this nasal airway into the opposite nostril and attach it to your ventilation apparatus. Insert your nasotracheal tube using the other nostril and listening to breath sounds to guide the tube to the trachea. This technique is particularly helpful during blind nasal intubation in young children after induction of general anesthesia for surgery. An adequate depth of inhalational anesthesia is maintained during the intubation process while the patient continues to breathe spontaneously. Note that the breathing circuit is open and will allow waste anesthetic gas to escape into the room. Be aware that the tip of the nasal airway can deflect the tip of the nasotracheal tube away from the larynx if it's long enough. Withdraw both the tube and the airway slightly and try again. You can use the same nasal airway to assist or control ventilation during the intubation. Close the mouth, occlude the other nostril until you can place your nasotracheal tube into it, and ventilate. Your manual breaths now provide the breath sounds you need to guide the tube. While this technique can be used in the emergency situation, the use of a rescue breathing device such as an LMA would be more appropriate to minimize the time required to establish good ventilation. Fiber optic bronchoscopy is often combined with nasotracheal intubation in hospital settings. The bronchoscope can act as the ultimate guide since it allows you to enter the larynx under direct vision to guide your tube into the trachea. Oxygenation and ventilation are the top priorities. Good airway management doesn't always mean intubation. It means ensuring an open airway and providing adequate ventilation and oxygenation. It's unfortunately easy to develop tunnel vision in an emergency and forget this basic principle. Provide supplemental oxygen. Place nasal prongs, a face mask, or simple oxygen tubing near the patient's mouth during the process. Always be prepared to suction secretions if the patient can't protect their own airway, because aspiration can easily occur. Constantly monitor the patient to ensure adequate respiration, airway protection, and hemodynamic stability during the nasotracheal intubation process.
How you doing? Nice deep breaths, okay? That's great.
Check blood pressure, pulse rate, and if you have it, oxygen saturation. Reassure the conscious patient and tell him what you're doing.
Squirt some of this local anesthesia down this, and you might cough again, okay? Are you with me?
Nosebleed is the most common acute complication of nasal intubation. When a nosebleed occurs, the treatment depends upon the severity as well as the clinical situation. If bleeding is severe enough to cause blood to accumulate in the posterior pharynx, then remove the tube. Compress the nose on that side firmly against the septum. Suction the oral pharynx frequently. You may have to position the patient in Trendelenburg or on the side to allow the blood to pool away from the larynx. If you haven't already done so, apply a vasoconstrictor, such as phenylephrine spray. With severe bleeding in the elective situation, stop the intubation attempt. As mentioned earlier, submucosal dissection can occur if the tip of the tube tears the mucosa and slides underneath it. Signs of a submucosal dissection include no tube visible in the posterior pharynx once the tube has turned the curve, the absence of breath sounds through the tube, the presence of a bulge behind the tonsillar pillars, complaints of pain in the back of the throat in the awake patient, and significant resistance as you advance the tube. When a nasotracheal tube is submucosal, remove it carefully. Be prepared for a heavy nosebleed. Consider postponing elective surgery because of the risk of retropharyngeal hematoma and abscess formation. If nasal intubation is still indicated, control the bleeding, try the other side, and proceed carefully. Watch for airway obstruction due to potential swelling. Ensure adequate ventilation and oxygenation. Monitor vital signs carefully. Remember, hypertension and tachycardia can worsen hemorrhage. Make sure there is good IV access. In cases of severe bleeding, a blood transfusion may be needed, so consider sending blood for type-in screen and cross-match testing. If bleeding continues, consider requesting consultation from a head and neck or surgical specialist. If intubation is not possible and ventilation is inadequate, consider a surgical airway. Prolonged intubation can mechanically obstruct the sinuses, predisposing to infection and leading to sinusitis. Consider switching a nasal intubation to an oral one if prolonged intubation is needed and patient safety allows. Nasotracheal intubation is a very useful technique, especially in an emergency or challenging situation. As with any skill, nasal intubation takes practice. However, to become an expert, you must master not only the skill, but the anatomy, theory, and tricks of the trade that accompany it. Care must be taken to avoid trauma to the nasopharynx and to safeguard the patient before, during, and after the procedure.